So primarily, what I'm going to do today is to give you a brief idea about what kind of things are important for you as a physician to know about psychiatry. I think one of the best ways to gauge what are the things you require for uh, in psychiatry to know as physicians is actually to read the Davidson's chapter which has psychiatry, and that covers, I think, 80 to 90% of what you need to know. And if I remember correctly, it's only 30 or 40 pages. So if you read the Davidson's Principle of Medicine, the psychiatry chapter, you will get a fairly good overview of the things you need to know. Now, see, essentially what you need to figure out is that as students or practitioners wanting to do MRCP, they don't expect you to have knowledge of a specialist psychiatrist. What they expect is, can you safely understand and manage the liaison aspect of psychiatry? So if an adult comes in a confused state, will you be able to at least have an idea what is happening? If a person comes to the emergency department, or if a person is admitted in a medical admissions unit who is on psychiatric medicines, would you know about the side effects of the psychiatric medicines which the person is taking, and whether you will be able to figure out the physical symptoms, the signs and symptoms of the person coming to you? Is it drug related or iatrogenic? The other very, very common thing is in medicine practice in UK are overdoses. So people coming to you with overdose of various drugs, overdose of alcohol, and other substance misuse. So essentially, you will need to know the domains where there is an overlap of psychiatry and acute medicine. And Davidson's Principle of Medicine gives you a fairly good idea about that. Now, what I'm going to do is I'm going to give you about 20 MCQs. We will discuss it, and please feel free to respond. These MCQs are just kind of overviews of what you can expect. Obviously, 20 MCQs are not going to cover the entire psychiatry syllabus, but I think it will give an overview of what kind of questions you can expect. So let's start with that. Yeah. So all of you know about anorexia nervosa, I'm assuming. Anorexia nervosa is one of the commonest forms of eating disorder where there is a body image disturbance. It is found in adolescents, it is found in adults, it is more common in women, it also occurs in men. I think the ratio of women is to men is actually, I think 5 or 7 is to 1, but it is much more commoner in women. And so there is a gross body image disturbance. There is a reduced BMI, and also a lot of the sufferers, they restrict their food intake and exercise heavily to attain their ideal body shape and ideal body weight. So, any guesses out of these? So, if you read the question and guess what is the correct response. Now, there is, because of starvation, there are a lot of metabolic changes, physical changes occurring in the person. So often adults with anorexia nervosa gets admitted in a medical ward for managing medical emergencies. So that is how there is a link between how a physician will come across someone suffering from anorexia nervosa because of the acute medical management. So any responses here, or shall I?
Impaired glucose tolerance.
Absolutely. Perfect, perfect, perfect. The correct answer is A. Yeah. Actually, hypokalemia is common in patients with anorexia nervosa, not hyperkalemia. I will just go back to the previous slide. A decrease in cortisol level doesn't happen. It is actually just the opposite. It is increase in cortisol levels. So the next one, there's someone has responded in a chat. Okay, perfect. Right. So if you read this, I'll give you a minute to read and then, right. Any?
Hystericus.
Which one?
Globus hystericus.
Absolutely perfect. Yeah, it is actually quite common. Even in Indian patients, if you see, a lot of people would say that there's something stuck in their throat and they can't swallow properly and they become very anxious. It is actually a classic sign of anxiety disorder. Obviously, one needs to exclude all other important medical causes. If you read the last paragraph, it is very important that as physicians, you need to exclude other causes of the sensation of food getting stuck in the throat before concluding that it is an anxiety disorder. So the last paragraph is very important, that it is a diagnosis of exclusion for physicians at least. And actually for everyone, because we can't really automatically jump to the conclusion that it is anxiety disorder. It will be a gross mistake if we do not exclude any other medical causes. How many of you have seen tic disorders? What is a Tourette syndrome? What are tics? Have any of you seen it?
No.
It's actually quite common, in the community, particularly in young children. Tourette's disorder or Tourette syndrome comprises of
teeth grinding.
Of?
Teeth grinding. No.
Here, teeth grinding. Okay. Any other answers? So let us discuss a bit about what is Tourette's syndrome. Tourette syndrome or Tourette's disorder is named after a person who first described it, Gilles de la Tourette. It usually begins in childhood, as people as young as 3. The peak age of onset is around the age of 7. And usually what happens, there are multiple vocal and motor tics. So what happens is there would be different kinds of noises being made like this. These are vocal or phonic tics. Along with that, there might be motor tics. So motor tics might be just blinking of their eyes, shrugging of their shoulders, contracting of their abdomen, odd movements of their hands, elbows, so there might be movements of the perioral area, there might be movements of the periorbital area. One of the most important things in Tourette's is that these symptoms can fluctuate. So if you see a 10-year-old child or a 15 or a 16-year-old boy with some vocal tics in, say, January, that vocal tic might disappear in February and some other form of vocal tic might come. Similarly, with respect to if you see a child with a motor tic, they might be shrugging their eyes for say 15-20 days or blinking their eyes. In the next 2 or 3 months, they might have something abnormal movement of their shoulders. So the vocal and motor tics fluctuate in intensity. One form of tic gives way to another version of tics, but the whole syndrome is continuous, and you need to evaluate on the basis to come to a diagnosis that the tics is present for a substantial amount of time. I think as per the guidelines, it is 1 month or 3 months. I have forgotten the exact duration. Now, in order to make a diagnosis of Tourette's disorder, presence of vocal and motor tics are required. Shouting obscenities like, bad words, curse words, is known as something as coprolalia.